Hi everyone, this is Hani, one of your ultrasound faculty, and I'm going to spend some time talking with you today about right upper quadrant ultrasound use in the ED. I love gallbladders, and I find that doing a bedside ultrasound really helps to speed me up in the workup of patients that present with abdominal pain. So I'm excited to share some of the tips and tricks that I've learned along the way. In this lecture, we'll cover the how. We'll start with the basics of the right upper quadrant ultrasound. Then we'll move on to evaluating for stones, for cholelithiasis and cholecystitis. And then in the more advanced lecture later today, we'll talk about mastering the CBD. We'll start with the basics. When doing this exam, the probe of choice to use is the curvilinear or the abdominal probe, but you may also find yourself having to need to use the phased array or the cardiac probe for one of the techniques that we'll cover here in a little bit, because this probe actually helps you to squeeze in between the patient's rib cage and evaluate the gallbladder. Just a PSA about gallbladders. They come in all different shapes and all different sizes. They're hard, and I think gallbladders are one of the most technically challenging studies that we perform in the ED. The gallbladder is really only attached at the neck, so that makes it a really highly mobile structure, and it can sit in various positions. And it can also have a lot of different folds, septations, and really lie anywhere between the midline and the mid-axillary line, so you'll have to check a bunch of different places. So there are 3 different techniques that you can use when evaluating a gallbladder. The first, and my favorite, is the subcostal sweep technique. Next is the X-7, or the intercostal approach. And then last is the right axillary approach. Typically when I'm doing these exams, I follow a specific order. I'll typically start with the subcostal sweep method and then move on to one of the more advanced methods, such as the X-7 or the right axillary approach. So I typically start with the subcostal sweep method. This is done by putting the ultrasound in the patient's epigastric region with the indicator pointing first up towards the patient's head. And then I do this sweep underneath the patient's rib cage from the epigastric region until I reach about the end of the right upper quadrant. In most cases, the gallbladder lies posterior to the inferior margin of the liver, and you'll find it somewhere around here in the midclavicular line. It's important to note also that you really want to direct your ultrasound waves towards the patient's right shoulder. So similar to how we do the subxiphoid approach for the FAST exam, you're really trying to sneak the ultrasound waves and their beams underneath the patient's rib cage. So this is what a gallbladder in the long axis view looks like. Let's start by reviewing some of the anatomy. So the first thing that you hit is the liver here. Next to the liver, you'll actually see this hypoechoic round structure, and that's the gallbladder lumen itself. Down here, this vessel that we're seeing is actually the IVC, and this is our kidney here on the right. It's important to also find the portal triad and the portal vein, because the gallbladder classically in the long axis will always point towards the portal vein. So here's our gallbladder in the long axis. Here's the fundus of the gallbladder, the body of the gallbladder, and the neck of the gallbladder down here. And again, it points towards the portal vein, which we see right here. And that's that classic exclamation point, with the top of the exclamation point being the gallbladder itself and the point being the portal vein that we're so classically taught. Here's another gallbladder in the long axis view. So again, remember, gallbladders come in all different shapes and sizes. So this is a relatively skinny gallbladder with some folds in it as well. But you see again, the gallbladder lumen itself points towards the portal vein, which you identify here. So this is a little bit of a more curvy exclamation point. Then you'll rotate the probe about 90 degrees so that the indicator is pointing towards the patient's right side or in line with the indicator on your screen to get the gallbladder now in the short axis view. Again, press down because you're really trying to sneak the probe underneath the patient's rib cage. Here's what you'll see. Again, you're seeing the liver here, the patient's right kidney here, and this round circular structure that's popping into view here, that is the gallbladder just in a cross-sectional view. Down here is the portal vein again, so you see again the gallbladder pointing right towards the portal vein. So here's that same long, skinny gallbladder that we saw in the earlier example, but now in the short axis view. So again, this is the patient's liver, next to that is the patient's right kidney, and here is our gallbladder from the neck all the way through the lumen of the gallbladder and through the fundus of the gallbladder here. So if I'm not able to see the gallbladder in the subcostal sweep approach, I'll change gears and then try the X-7 approach. So this is done by putting the probe in the epigastric region and moving it about 7 centimeters into the patient's right upper quadrant. And what you're trying to do now is actually look at the gallbladder in between the patient's rib spaces here. It's probably best to use the phased array probe for this technique because it really allows you to sneak in between the patient's ribs a little bit more easily than the abdominal probe. And here's what it looks like. Again, this is the gallbladder in the long axis view, but what you'll notice is that on each side of the gallbladder is a patient's rib. The ribs do tend to get in the way, which is why I reserve this for when I'm unable to see the gallbladder in the subcostal sweep method. Here's that same gallbladder in the short axis view, but what you'll notice is it's flanked on each side of the gallbladder by a rib shadow, and that's why I reserve it for when I'm unable to see the gallbladder in the other approach. The axillary approach is one that is also very familiar to us, so you would actually position the probe where you would for a fast exam in the patient's right upper quadrant, but in the mid-axillary line. And what you do is you now aim, instead of downwards, evaluating for free fluid, upwards and more lateral to see the gallbladder. And here's what it looks like. Again, your ultrasound is positioned in the same spot where you would for a fast exam, but now, instead of pointing the probe downwards to evaluate for free fluid, you're pointing the probe upwards towards the ceiling to evaluate the gallbladder itself. It's important to pay attention to the anterior wall of the gallbladder as well, because certain conditions can cause the gallbladder wall to appear thick. We typically measure the gallbladder wall in the short axis view, as you see here. The spot that you actually want to measure is the anterior wall at where the gallbladder interfaces the liver, because this is the most crisp part of the gallbladder wall. We typically don't measure the posterior wall for a few reasons. One is that often stones will sit down here and may give you an artificially thickened wall. And two is that in ultrasound, we have this phenomenon called posterior enhancement, where the ultrasound waves will hit the fluid of the gallbladder wall itself and cause a brightness to everything posterior to that. And that phenomenon can actually make the posterior wall appear artificially thickened. The cutoff that I like to use is about 3 millimeters, and anything less than 3 millimeters or 0.3 centimeters is normal. The way I remember that is that there's 3 L's in the letter gallbladder, so 3 millimeters is my cutoff. Take this with a grain of salt because many different things can actually cause gallbladder wall thickening. I break it down into a few different categories. The first is any sort of edematous state, such as heart failure, cirrhosis, renal failure, etc., will actually cause your gallbladder wall to appear thickened. The way I remember this is that the gallbladder's venous drainage is actually to the IVC. So if everything backs up, you'll then back up into the wall of the gallbladder and it may appear thickened. Next, I think about all the itis, or all of the inflammatory conditions that could cause gallbladder wall thickening, such as cholecystitis and cholangitis, but it's also important to know that any sort of hepatitis or pancreatitis or any other surrounding inflammatory pathology could also cause your gallbladder wall to appear thick. Next, I think about the neoplastic causes, such as gallbladder wall carcinoma or metastatic disease. There are also a few physiologic reasons why the gallbladder could appear thickened, and fasting is one of the most common reasons. And then last are kind of this other bucket, where I think of adenomyomatosis or malabsorption or cystic vein varices, but these are a little bit more rare. Here's an example of a contracted gallbladder, and one that we would want a repeat ultrasound in about 6 to 8 hours. So what you see here is the gallbladder is nice and thin and contracted, but more importantly, you're actually able to see the layers of the gallbladder itself, which has 3 different layers, so bright, dark, bright, and that is indicative of a contracted gallbladder. And here's another example. So again, this is a gallbladder in the short axis view, and what you're noticing is that anterior wall of the gallbladder right here appears to be pretty thick, greater than 3 millimeters. This is actually a case of gallbladder wall thickening secondary to hepatitis. So the takeaway from this is just know that certain conditions can give you gallbladder wall thickening. So I know what you're thinking, but how do I make it look like that? Gallbladders are probably one of the most technically challenging studies that we perform, so here are a few tricks that I've learned to make my images a little bit more clear. The first is have the patient take a really deep breath in and have them hold their breath. This will actually push the gallbladder downwards towards the patient's feet and out of the rib cage, making it a little bit easier to see. Next, you can also have the patient roll into the left lateral decubitus position. This will actually have the gallbladder somewhat flop over into the epigastric region and make it a little bit more anterior and easy for you to see. And then last is try a new technique. So I typically start with a subcostal sweep approach, but if I'm having a hard time, then I'll typically change gears and try the X-7 or the anterior axillary approach. And that is the basics of the gallbladder ultrasound. We'll change gears and we'll talk about gallstones now, and specifically evaluating for cholelithiasis. So similar to gallbladders themselves, gallstones, again, come in all different shapes and all different sizes. You can have one stone, it can be large, it can be small, or you can have multiple stones. So this is just an added challenge when evaluating a patient's gallbladder. When it comes to gallstones themselves, know that ultrasound is really the most sensitive thing for helping you to evaluate gallstones. It's greater than 95% sensitive, and CT scan, on the other hand, is only about 80% sensitive. But when it comes to cholecystitis, HIDA is actually a little bit more sensitive than ultrasound itself, but we routinely do ultrasounds because it's more readily available. So gallstones themselves typically show up as these bright white or hyperechoic foci. They also will often cast a posterior shadow, but it's important to know that sometimes very small stones less than 3 millimeters, may not actually cast a shadow. And then last is to pay attention to the walls of the gallbladder. The gallbladder lumen itself should appear nice and smooth all the way around. If there are stones present, that wall will appear irregular. Here's an example of a gallbladder in the long axis view with a pretty large, obvious stone. Again, what you're seeing here is the patient's liver, and this is the gallbladder itself, and here is this very large gallstone that's near the neck of the gallbladder. Again, pay attention to what's posterior to the gallbladder, and you see here that this stone casts this very large, dark shadow behind the gallbladder. And here's the same gallbladder, but in the short axis view. So again, this is the patient's liver, and what we're seeing here is the gallbladder in a cross-sectional view. And at the start of the clip, what you're seeing is actually that bright white stone right here, and it's casting quite a big shadow posterior to the gallbladder. It's important when assessing for stones to keep your eyes on the neck of the gallbladder and the fundus. So here's a reminder of how the gallbladder typically sits in the long axis view. So what you're seeing here is the fundus of the gallbladder. This itself is the lumen of the gallbladder, and the neck of the gallbladder is down here. Stones often get stuck in the neck of the gallbladder as they're trying to exit, and typically stones that are impacted in the neck of the gallbladder will go on to develop cholecystitis, so it's important to get a nice clear view of the neck. The other spot where stones will hide is actually in the fundus. Remember, the indicator is pointed up towards the patient's head for this view, so that makes this the patient's head and this the patient's feet, making this the most dependent area of the gallbladder. So often stones will pile up in the fundus of the gallbladder. And here is an example of that, with stones in the gallbladder hiding in the neck. This is the gallbladder in both the long axis and the short axis view. What you're seeing in the long axis view is the presence of these hyperechoic foci at the neck of the gallbladder, casting this posterior shadow here. Again, pay attention to the walls of the gallbladder. It should be smooth all the way around, but what you're noticing when you evaluate the neck is this irregularity in the wall, which is indicative of stones. It's also important to roll patients too. Remember that impacted stones at the neck will often go on to develop cholecystitis. So if you roll a patient and you notice that these stones actually move out of the neck of the gallbladder, those stones aren't impacted. And those patients, if their pain is well controlled and have no other signs of cholecystitis, can be discharged and followed up with as an outpatient. Here's an example of stones hiding in the fundus of the gallbladder. So again, this is the long axis and this is the short axis view here. Upon initial assessment, it appears that there aren't stones in the gallbladder, but when you actually rock your probe down towards the patient's feet, you discover these hyperechoic foci with these shadows in the fundus of the gallbladder. Again, remember that the fundus is the most dependent area of the gallbladder, so it's important to look there to see if there are any stones present. So we're going to play a little game now, my favorite, called Stones or Nah. I'll show you a series of ultrasound clips, give you a little bit of time, and then I want you to tell me if you think there are gallstones present or not. Here's case number 1. Do you see any evidence of gallstones? No, there are no stones here. This one's pretty tricky because there's actually this fold in the gallbladder here, but again, there's no posterior shadow here, and this is not in a dependent area of the gallbladder, so this is no gallstones. Here's another example, and a little bit more challenging. Do you see any evidence of stones here? Pay attention to the neck of the gallbladder. When you initially look through this series of images, it doesn't actually look like there's stones there, right? But if you actually look pretty closely at the neck, you notice that there's this shadow right here. And I could argue in my mind that there's this hyperechoic foci hiding in the neck right there, which would be indicative of a stone that's stuck in the neck of the gallbladder. Here's another example. Do you see any evidence of gallstones? Yeah, I don't either. But did you actually catch this finding? There's actually hydronephrosis here. Really pay attention to everything going on in the right upper quadrant. Here's another example. Do you see any evidence of gallstones? I do. These are very small and these are very tricky stones to see. What you're actually seeing is these small little gravel stones kind of sitting in the gallbladder floor down here, casting this posterior shadow. Again, pay attention to the walls of the gallbladder. They should look nice and smooth all the way around, and you see this irregularity to the wall here. Pay attention to what's posterior to the gallbladder because you see these stones cast this big shadow all posterior to the gallbladder on both the long and the short view. Here's another example. Do you see any evidence of gallstones? This one's pretty tricky. This is actually what we call the west sign or the wall echo shadow sign. Pay attention to that portal vein, which we see pretty nicely here. The gallbladder should always point towards the portal vein, but what's happening in this case is that the gallbladder itself is just totally filled with stones from top to bottom. So you're seeing the wall of the gallbladder here, that anterior wall, and then this really profound shadow, which we call the wall echo shadow sign here, or the west sign. Here's another example. Do you see any evidence of gallstones? Yeah, this one's pretty easy, right? Again, you see this hyperechoic foci here casting this posterior shadow. Look at the walls of the gallbladder itself. They should appear nice and smooth all the way around. And what you're actually seeing here is this stone stuck in the neck and this irregularity to the gallbladder wall here, which is indicative of a gallstone. I would also roll this patient and make sure that the stone moves to ensure that it's not impacted. There are a few fake outs that you need to be aware of. The first is this. This is actually not the gallbladder. This is the duodenum that you're seeing here, which we commonly see since we have the probe in the epigastric region. The duodenum is distinct from the gallbladder for a few reasons. One, it typically doesn't point to the portal vein. And two, you see kind of this hyperechoic ring that sits in the middle of this lumen. That's actually bowel, and this typically doesn't cast a shadow like we classically see with stones. Here's another example of a patient with bowel next to their gallbladder here. Do you see the difference? You'll see peristalsis happening throughout this loop of bowel. So just another thing to keep in mind. Here is another fake out. This is actually adenomyomatosis. This is a benign condition. It's actually caused by diffuse thickening of the gallbladder wall. And you kind of get these little intramural diverticuli, which give you these small little comet tail artifacts. This is totally benign and something else that could fake your eye out for stones. And then here is another example. This is actually gallbladder polyps, and this patient has several polyps, which we see pretty nicely right here. Polyps typically don't shadow, and they don't move when you're rolling the patient around from side to side. They're also typically less than 1 centimeter in length. If you do see a gallbladder polyp, it's important to note because those patients typically need follow-up to ensure that they don't develop into a carcinoma. So that's gallstones. There's one thing I can have you take away. It's evaluate the entire gallbladder when looking for gallstones, especially the neck and the fundus of the gallbladder. If you do see a stone stuck in the neck of the gallbladder, roll the patient into the left lateral decubitus position to see that stone move, because impacted stones will often go on to become cholecystitis. So we'll change gears now and we'll talk about cholecystitis. But first, a PSA. Acute cholecystitis is a clinical diagnosis, and just know that imaging should only play a supporting role. It's pretty challenging because a lot of patients lack the classic findings of cholecystitis, especially early in the disease course. And many of the sonographic features that we use are pretty nonspecific. Things like anterior wall thickening, for example, which we know can be caused by many different things. So just take it with a grain of salt. So some of the findings of acute cholecystitis include, first, gallstones. There's been some pretty good data that's come out that says about 95% of patients with cholecystitis have gallstones present in their gallbladder. Just remember, something like acalculous cholecystitis is actually pretty rare in healthy patients. Next, you'll see a distended gallbladder. You can actually measure the gallbladder in the short axis view, and something greater than 4 centimeters would raise concern for cholecystitis. Think about this conceptually. The gallbladder is trying to push its bile out against an impacted stone in the neck of the gallbladder, and as it's unable to do so, the gallbladder itself will start to distend. Next, you'll see a thick anterior wall, greater than 3 millimeters, because there's 3 L's in the word gallbladder. Remember, this is a pretty sensitive, but not a very specific finding, because lots of different things can cause this. Next is the sonographic Murphy sign. This is done when you visualize the fundus of the gallbladder itself and apply pressure with your probe right over the fundus. And if the patient reports pain when you do that, that's indicative of a sonographic Murphy. And this is probably one of the more reliable findings of acute cholecystitis. And last is paracholecystic fluid. So this is a thin fluid stripe that kind of forms around the gallbladder as it starts to get edematous and inflamed. Just know that paracholecystic fluid is a highly specific finding for cholecystitis, but not very sensitive. It's not always there, especially in the early disease course. You don't need all 5 of these findings to diagnose somebody with acute cholecystitis. Just remember, acute cholecystitis is a clinical diagnosis, and the ultrasound is only an adjunct to helping you secure that diagnosis. Typically, if you see the presence of gallstones and the patient has a sonographic Murphy's, that is highly suggestive of cholecystitis. And some of these other findings, like the distended gallbladder, the thick anterior wall, and the paracholecystic fluid, happen typically later in the disease course. Here's an example of a patient with acute cholecystitis. We see a couple of pretty interesting findings. First, this is a gallbladder in the long axis view. You're first seeing thickening of the anterior wall of the gallbladder, which you see here. But just remember, we typically don't measure the gallbladder wall in the long axis. Next is you're seeing the presence of this hyperechoic foci, which looks like it's sitting in the neck of the gallbladder, which is right around there. That is a gallstone that's stuck in the neck of the gallbladder. Next, this gallbladder is pretty distended overall, and we see that pretty nicely here in this short axis view. If we were to measure greater than 3 centimeters, that would also be indicative of an acute cholecystitis. You're also seeing on the short axis here the paracholecystic fluid present, which is this hypoechoic fluid that surrounds the gallbladder itself, indicative of gallbladder wall inflammation. And last, there's that stone again, hiding in the neck of the gallbladder, casting that posterior shadow. Here's another example. So this is actually a patient with a perforated gallbladder from cholecystitis. Again, you're seeing kind of this sludge in the gallbladder itself, this pretty significant amount of paracholecystic fluid, which you see actually pretty nicely here on the short axis view. And then last is you see kind of this large fluid collection outside of the gallbladder. You see it in both views here, but that is indicative of gallbladder wall perforation. So that is cholecystitis. Just remember, it's a clinical diagnosis, and it commonly has 5 associated ultrasound findings, but you don't need all of them to diagnose somebody with cholecystitis. Remember, stones, gallbladder distension, thick anterior wall, sonographic Murphy's, and paracholecystic fluid. Those are the classic findings of cholecystitis. So that's pretty much it. In this lecture, we talked about the how. Remember, the basics of the right upper quadrant ultrasound, those 3 different approaches, but that I typically start with that subcostal sweep approach before moving on to one of the more advanced techniques. Don't hesitate. Let your patient take a big deep breath in or roll them into the left lateral decubitus position to really help optimize your images. Next, we talked about gallstones, cholelithiasis, and cholecystitis. Remember, stones come in all different shapes and sizes. They can be large or they can be small, so pay attention to the posterior shadowing. Second, cholecystitis is a clinical diagnosis, and remember that the ultrasound is really just an adjunct. In the more advanced lecture, we'll talk about the common bile duct and how to master finding the common bile duct, measuring the common bile duct, and what it may mean for use in the ED.